Lord. Now, week three, we're getting there. We know next week is going to be your first exam. Now, I will not be here next week. My husband's youngest grandson, our grandson, is turning 4, and mom decided to take him to Disney. I haven't been to Disney in, 25 years, I think, maybe 30. We are going to Disney, and we're going Thursday, Friday, Saturday, Sunday, Monday. Now, I do have somebody who's going to give you your exam. You're still going to get your grades on Saturday morning. Professor Stiles will be giving you your exam and giving you your lecture. I also will attach one of my lectures there so that you'll have it all covered. Everything you need. I am reachable. If you need me, there's not a problem. Please. It's better if you email me than just text, than just put it as a canvas, all right? So email me. It's bbogart@fortiscollege.com. And I do answer pretty quickly, all right? I'm going to the park only one day, and that's going to be Saturday because I want to see Magic Kingdom. I want to go to the roller coaster if it's still there. What is this? Something Mountain, it's called. I mean, I haven't been there, I'm telling you, in so long. So it'll be great. It's all family. And that's what it's all about, being with family for time. And we're going to do that. So when you don't see me, don't get concerned. I will send you all the information you need. So on week 3, we just have those NCLEX questions. And again, make sure you go to growth and development. If you're having a trouble and you can't get that open, it should be loaded into, module 3, be able to just hit NCLEX questions and load NCLEX. If it is not, because I've had people tell me this too, fill out a help desk ticket. The help desk ticket is on your homepage. And if you have any other problems, let me know and I'll give you also, how to do that. Again, when things don't transfer, CJ Sims, I do. NCLEX questions, I do. The ones that will transfer by themselves are on week 10, the pediatric assessment, assignment, and practice exams right before HESI. So any questions about anything? I'm going to really appreciate your patience today, and I apologize. I have the highest paid internet. Last night, my husband was on the phone with them, checked it. They told me it was good. And this is my second modem in the last 6 months. And I had one before that. So this is 3 in the last year. So I've done everything I can. It's out of my hands, but I will be getting another microphone, seeing if I have my desktop can work. It's an old desktop, but it should. Anyway, variations, adaptations, talking about children in hospitals. We've already gone over how to take care of kids, how to approach kids, how to make them feel comfortable. And if we do that, children will do what you want them to do. It's just that you are scary because what do we always do as nurses? Usually they grew up getting immunizations and we're always giving them that needle, right? So we are scary. Make yourself less scary. There's always an objective on these telling you what's going on. Consents. In pediatrics, parents sign the consent, or if you're adopted, or if it's, you're just the person taking care of them, the legal guardian, those papers must be there in order to get medical treatment. In an emergency, nobody has to give any sort of consent until after, because if it's an emergency, two physicians can say, hey, this kid came in on a helicopter, was hit, we need to take care of him or they're going to die. We're going to take care of the child. And then we'll worry on consent. And then the other thing is, remember, emancipated minors, they'll have paperwork for that. And children who are 18, cognitively aware, they will sign their own consents. And you need permission from the child to even talk to the parents, okay? That is a difference. ID bands are the most important thing and have decreased medical errors like crazy. Any unit in the hospital, whether it's pre-op, whether it's on a floor or ER, they are always doing ID checks to make sure that those bands are on because we need those now. What's good is now we have to scan them to give meds. So we know that that has to match to give medications. It's really decreased the amount of errors that have been done. Now, safety. Now you're talking about kids that are from newborn up to 18, actually to 21. They go to the pediatric um, hospitals or areas. Safety, very important. Well, that little one on top, that crib, if you notice there's a top area and you pull up the side rail, pull down that plastic, those are for your toddlers who like to climb out of things, right? You're not always, or a parent's not always, watching. They can go to the ladies' room, right? They can go to the cafeteria, and they do. They will climb up and get out. So always be careful with the younger kids, making sure there's a proper type of crib. If they're climbing and standing, they need a top on it. So, one of the other things is if you notice at the head of the bed, there's usually a button for code blue, there's O2 equipment, AMBUs, all things. Remember, children like to get into that stuff. So have it pulled away, they can't reach it. Or you'll be having a code blue with a kid hitting it and everybody running medications, peroxide and betadine, again, keep them out of their sight. Um, and one of the other things is we want to, please our kids, and we tend to take toys and from kid to kid or the playroom to kid, make sure that they're cleaned before we give them to another kid. Because as I said, like in daycare, all they do is swap spit, right? Toy to toy to toy to toy. But now they're in a hospital. And the hospital, they're sick for some reason. You don't want to cross contaminate them. And then always proper universal hand washing and gloves when needed. And oxygen supports combustion, so always be safe with it. Children who are up and out like to go to that little alcove that has stretchers and wheelchairs and play with it. It's one thing that we shouldn't allow. They're going to pinch their fingers, they're going to hurt themselves. A baby who's up and out of bed in a high chair or a swing or something like that should never be unattended, even if they're strapped in. I can't tell you how many children were out at the nurse's station strapped in a, a high chair or in a swing because they needed that attention and their condition allowed that, right? Small kids should never be left alone in the room by themselves. And I'm talking, your young 1, 2-year olds. They can get into a lot of things. And always they say never prop a bottle because they can choke and gag on it. And that's whether they're home or in a hospital. Now, transporting children can be fun. Um, they do have these red wagons, those flyers, and they do use them. And what's neat, they do have like little seats and little straps to strap them in. Always use whatever harness is there for them. Also, another way we do it, have the parents sit if they're there, put the child in their lap. You know, we must be safe and they can't just carry them. We're responsible for them. So if a parent trips and falls and hurts the child, it's our responsibility, okay? Whenever they go to another area, x-ray, maybe they go for a CAT scan or a procedure, always make sure their ID band is on and it's the correct name. I've seen wrong names. And always cover yourself. Baby went to CAT scan with transporter ID in place, chart went, date, time. You release, okay? Now, taking care and looking at kids and collecting specimens, children are different. You can't just go in and say, I'm going to draw blood. The kid's going to put their arm out and they're going to give it to you. We know that there's a process for it. Also, we're going to use different size needles, different size catheters, right? We're not going to put a 12 French catheter in a newborn to get some urine. It's going to be special equipment. They're going to be, what about a blood pressure? You're not going to use an adult blood pressure. You're going to be using whatever size it is. They have from zero, all the way up to 6. Then it's small adult, extra large. So there's all different sizes. We don't want to have an improper measurement because we need that, okay? Whenever we give a procedure, you always must say how the child responded to it. Did they tolerate it well? Or, did it require coaxing? All of those things need to be documented. Now, how do you assess an infant? Well, I like it somewhere quiet, okay? On mommy's lap is the best. Is part of my dissertation about parents holding their children procedures. It's a program called Huggies, like the diaper, but it's H period, U period, G period, GIES, right? And you Google it, you'll see it. It's there. It's about help us give injections efficiently and safely. And it's a program that the hospital that I worked at still utilizes because it describes how a kid can be assessed the best, right? So get the kid quiet in mommy's arms as possible. Talk quietly, and you're going to go slow and easy with it. You're not trying to go in there and get it done quick. You're not going to get it done quick. But the slower, the quiet, give them a pacifier. They self-soothe that way, right? And as you're sitting and listening and looking at things, you're going to be talking quietly, telling the parent what you're doing. And then what are you doing? You're teaching, aren't you? And of course, after your assessment, you're going to document it. Now, children, they
Are you guys still on here?
Yeah,
Yep.
she's frozen.
There you are. I apologize. So, basic data collection. The big thing about children, you can look at them. The sick child looks sick. The well child doesn't. So we have this thing, well appearing, sick appearing. If they look sick, they're pale, they're not walking, they're limping. You can tell just by their face. They don't look good. When we get a kid, we always do a height and a weight. It's going to see, is their size appropriate? Also, we're going to see how the kid is acting towards us. Are they alert? Are they happy? Are they sad? You can tell they're in pain. Children, especially the smaller kids who can't tell you what's going on, let's say they're like this and hurting their head and they're hitting their head or touching their ear. That's probably an earache. Sticking the fingers down the throat. They're telling you something's wrong with their throat. Or that kid whose legs is moving, probably their tummy hurts. So just by looking, we can tell a lot of things, can't we? Another thing we're going to look at is always be concerned and check for any signs of child abuse. As a nurse taking care of children, you want to make sure they're safe. So looking for those, if there's any bruises, and of course at various stages of healing, yellow, green, purple, what color is that bruise? It's going to tell you. And then of course, a normal kid who wasn't out playing when they got hurt, how clean are they? What does their clothes look like? All of those things are going to tell you things. So when we're going over again anything, finding out about a child, examining the child, assessing the child, we're going to be talking to the parents. If it was an injury, talk about, all right, so the kid was fell down the stairs, the kid's 1.5, do you have those things up to prevent them from falling? And if not, talk about the importance of them. Also, we don't think many years ago, we didn't even conclude it, but what about there are families and cultures that believe in alternative things? Great example is my husband. Being Jamaican and you get a cold, sick, your tummy hurts, diarrhea, vomiting, doesn't matter. He thinks ginger and garlic tea helps. But just think about G and G both prolong bleeding. What if that kid was on blood thinners? Okay, now you've really created bleeding. So you've got to, find out what are their beliefs, what do they use. It seems simple, simplistic, but it can cause problems. We're always talking about what do they take for fevers. You'd be surprised even today. You'll see parents say they gave them an aspirin, and you're like, no, you should not be giving an aspirin to a child. Um, you can get Ray's syndrome. It's usually after like a viral infection. Like you had the flu a couple weeks ago and you gave them aspirin and now they have Ray syndrome. That's how it happened. So never aspirin. So asking, what do they give? Is it acetaminophen? Is it ibuprofen? And if they're given ibuprofen to an infant, they can't give it till they're 6 months old. So we can stop a lot of dangerous things from happening just by asking questions and teaching as we're assessing. How do they eat? Have they been healthy? Do they sleep good? If they're getting into toddlers, have you tried potty training yet? And then, especially if you have to admit a child, what are those things that he says that I need to recognize? Like this little thing with the hands, putting them fingers together means they want more. I never knew that. But through asking parents, I found out the kid wants more milk or more whatever it is. Looking physically, head to toe. Now remember, you're not going to do a head to toe assessment. It's not going to happen in most kids. You're going to be able to probably do a quick focus and then get the rest when you can. If an infant's asleep or a child's asleep, oh, that's the best time for breath sounds. It's also a great time to listen to the heart because if they're up, even the infant will be cooing and moving, and you don't hear that well. Vital signs tell us a lot. What's the temperature? Height and weight's going to tell us nutrition. And as they get older, maybe it's a hormone imbalance of some sort, growth hormone problems, thyroid problems. So, very important to measure them. And then, of course, heart rate and respiratory rate and blood pressure. If your temperature's up, your blood pressure's up, it's not, low and your heart rate's up, that's normal because your vasodilated blood pressure drops, but that heart rate's trying to keep it up, right? Hydration. How do you look at hydration? Well, number one, capillary refill. Is it quick or is it prolonged? Looking at their lips, their tongue. Infants, that good old fontanelle tells us a lot, right? Sunken eyeballs. I've seen those on infants and even up to toddlers. And then are they pale? That's another one. Looking at the skin, it's not just only if there's tenting and dehydration in the color, it's looking, is there any rashes, et cetera, et cetera. Now, taking a pulse and a respiration on a child, it is different from infants up to older children. Now, we can do on older kids radial, we can do temporal, mandibular, femoral, carotid, but they say with children, an apical is first. I've never done temporal mandibular for, femoral or carotid, just generally, just routine. It's always either been a radial, brachial, or a apical pulse. But on children, accurate, it is an apical pulse. After 5, you can do the radial pulse on them. Respiratory rate, how deep, how fast, these things are important. Again, remember, heart rates go up for several reasons. It could be an elevated temperature, it can be dehydration, it can be pain, right? Those 3 things can elevate it. And as I already said, in infants, watch them. I just put a little hand on their chest and I'll count respirations that way. They're quiet before you disturb them. You do it first. As I said, blood pressures, all different sizes of cuffs. You just have to, after a while, you learn which one works. The cuff should be 2/3 of the upper arm. On a lot of kids, especially those toddlers, I'll use it on the lower leg because it's less invasive. They don't mind it as much. Those electronic blood pressure machines, I make them a toy. I have the kids push the buttons. I have them guessing numbers. And again, it's not going to be threatening to them. Blood pressure cuffs and readings. If the kid is just screaming and kicking, it's not going to be an accurate blood pressure. Now, fevers is due to a lot of different prostaglandin hormone things going on. But the thing about fevers you need to know is that a fever in itself is not dangerous, okay? 506 fevers, no seizures, no nothing. But why do we give medicine to a fever? How do you feel with a fever? You feel horrible, right? You can see a child with a fever and they're sitting in the corner, they're not eating or drinking. They look sick. Give them that acetaminophen, ibuprofen, and what happens? Fever comes down and they're up and playing again, and they're going to drink liquids for you, which is what you want with a fever because they're losing extra fluids, right? Now, hyperthermia, it would be if let's say they're stuck in a car, mom goes running somewhere, they're in a car, and their body gets hot. It's nothing to do with a fever. It is dangerous. Acetaminophen, ibuprofen's not going to bring that fever down. You've got to put a cooling blanket and ice on these children to get it down. And there are these cooling machines we use. We Did you hear about hyperthermia and the difference between a fever and hyperthermia? Okay.
Um, a little. I heard a little. I heard you say that with hyperthermia, we're supposed to treat with a cooling blanket and ice.
Right, and a continuous temperature so that we do it slowly and we watch it come down. Tylenol and Motrin don't work with hyperthermia, okay? That's the difference between a fever and hyperthermia. Now, there's all different ways to do temperatures. Honestly, go to the dollar store, get one of those little digital thermometers, and they work great. There's some parents who like the fancy ones, whatever works for you, okay? When they first came out, there was a little bit of discrepancy, but they're a lot better than they used to, okay? Now, pain. Children, they can tell you they have pain when they can't even talk. Now, the first scale we use is the flax scale. This is from newborn up to age 3. At age 3, it'll be faces where they can point to a picture. Now, the flax scale is also for children who can't talk, nonverbal children. It could be a 15-year-old cerebral palsy child. They can't talk, right? Or can't express, but you can look at their face. Are they grimacing? Their legs, are they moving? Are they thrashing? And that's the activity too. And then crying and consolability. Can you console the child or not at whatever age? What's really good about these younger children, ages 3 up to about age 8, they say faces scale. And then you can give them the 1 to 10, the numeric scale. They'll point to the picture, and children are honest with their pain scale. Adults are always a 10, right? Not children. Now, weight. Weight is important. Children are always changing weight. We need medications, right? When you give medications, you want an accurate weight. Milligrams per kilograms, micrograms per kilograms. That's how we give dosages of medicines in the hospital. The height, again, are they growing the way they should? It should be at the age of 2, they stand up and put the thing on their head. And again, a 2-year-old, sometimes that can be difficult. Again, I make it a game. I put me there, I go, look, I'm a number 7. What number are you gonna be? And now it becomes a game, okay? Before that, put them on the stretcher. It's usually paper on it. Draw their head, draw their feet, measure it with a tape measure, and that will be your height. Why do we do height and weights all the time? What does that measure? It's a lot again, right? I'll say it again. Nutrition. It also looks at maybe some sort of metabolic problem, thyroid or growth hormone or something. Remember though, height is reflective on the family. If the family are short, the kid's going to be short too. Head circumferences we do on infants and toddlers, usually until that soft spot closes. And we're making sure that the cerebral spinal fluid is moving down and not causing water on the brain or hydrocephalus. Usually in the newborn ICU, you're going to do on your first assessment a head circumference, okay? And you could see exactly where you do it. Kids don't mind. Collecting specimens. The one thing about children, especially if you have to draw blood, make sure it's labeled and sent properly to the lab. The lab will not accept unlabeled specimens. Can you imagine telling a mother you have to stick another needle in their 6-month-old infant because you didn't label the specimen? That would be horrible, wouldn't it? So when we do the specimen, make sure that we, verify it. We get the specimen using proper needles, proper equipment, make sure it's labeled, and then of course sent to the lab the way it should and document it. Urine is done different. We usually on infants only straight calves. We want to make sure we're not getting just all of, contaminants using a bag. The only time we would use a bag for urine is if we just need a specimen arbitrarily, that where it doesn't make quote a difference in the care. We just want to see, let's say, a glucose in the urine or a protein in the urine. But everything else, when we're looking white blood cells, looking for infection, is a cath for young kids. After that, clean catch. And I've seen parents take the kids, take their underwear off, stand them on the sink, wipe them off and say, all right, go. And then they catch it as they're going, or in the bathroom, standing them on the toilet and getting that. But as long as it's a good thing. Cerebral spinal fluid, again, making sure that it's labeled because again, they won't accept it. And then you have to do that again. So always, always, always be careful. Now, urine can't be squeezed out of a diaper, okay? The only time that we have done that as nurses is just they want a glucose. That is okay, but everything else we do not do it. What we can do is we put a cotton ball inside the diaper, and that will. So, a nurse is admitting a 3-year-old boy has a high temperature, they're restless and crying. What safety measures should the nurse institute on admission? Well, 3-year-old, that's a toddler, right? What are you concerned about? Safety. Anybody?
You could be concerned about the fever going too high and like causing a seizure, so maybe seizure precautions.
Okay, absolutely. Seizure precautions and making sure that they're medicated properly and when we can, right? Also, 3-year-old, there are going to be moments in time where our eyes aren't on them constantly. So putting them in one of those bubble top cribs, right? Making sure that they're not going to climb out and side rails up all the time. And remember, the head of the bed, all of that equipment, and that code blue button they love to punch. Make sure that it's away from them. Toys, nothing little they can put in their mouth and choke. There's just so many things with safety that if we think about it on these age children that we have to protect them from. So understanding medications, how it's given, goes back to pharmacology. And we know children, infants, and the elderly both are almost the same about absorption, distribution, metabolism, excretion. Older people, don't absorb it quickly because their stomachs maybe have an ulcer or whatever. Children are just young, they're immature. How it gets to the body, I mean, that again depends on the child and the condition. Metabolism, how fast is the heart beating, makes a difference. And then, and the liver, how is it absorbing it and getting it to that substance that we need to use? And then, of course, urinating. If you have a child who has problems with the kidneys, we're going to be very concerned about giving medications, even with an adult, right? Because if we give it too much, their levels are going to be high. They can be toxic. Very, very important that we remember those things. You might see a kid all of a sudden not look right. And it could be because the kidneys aren't working, they're not urinating, and it's the medication that's climbing up. And I'm telling you, many times it's the nurse who figure these things out. So absorption, what makes that difference? Well, their stomachs, did they have milk or did they eat before they get the medicine? That makes a difference, right? Their intestines, the young kids, they're not absorbing well. It comes out and it's not really used. And adults, it could sit there too long and get too much absorbed. So you've got the ends of the spectrum there. Topical medications and ointments. I saw one case where a father brought in his son who has just finishing an antibiotic and he went in a rash from head to toe. This father gave him a dose of oral Benadryl and because the rash was itchy, rubbed him head to toe with Benadryl cream lotion. The kid came in overdosed on Benadryl in a catatonic state. We waited for it to go away. There was no untoward thing, but my point is that topical medications can get absorbed. I apologize again and again and again. Now, parental medications, P, parenteral, anything with a pinch. That means something with a needle. When you give parental medications, once you give it, you can't take it back, especially IV. So the rule of thumb is make sure you're giving proper dosages. Metabolism is how the body, the liver, metabolizes and makes that medicine into what the body needs, okay? Again, you see in children up to ages 2 to 4, their liver is still immature. So the metabolism of medicine isn't like, a young adult. So we need to keep this in mind when we give medications. Excretion. Kidneys are really immature under the age of 1. So we're not urinating it as much. And again, you're going to watch for those overdose. So with medications, the stomach is not emptying quick because it doesn't function that well. The intestines work too well, so you're not absorbing anything. Liver can work well or not so good, and the kidneys the same. All of these put children at high risk for toxicity with medications. Now, when we talk about medications, giving it to children, sometimes it's their first dose, they got an antibiotic. So if a parent's there, you're going to have them watch for you. Look for a rash, swollen lip, difficulty breathing, coughing. These are signs of pre-anaphylaxis, right? So making sure that we observe for them. And always, if we've given a medicine, we're always going to document, especially first doses. And you know something? Kids on the last dose of antibiotics like to have reactions too. Make sure that we are documenting it, and always, always with children, always make sure that dose is safe. Now, I always use parent teaching all the time. I'm talking to the child in a very quiet, calm voice, but the parents are listening to me. And it does two things. It teaches the child and it teaches the parent at the same time. So they're on the same page. So when we have medications that need to be given, we need to tell them why. Why am I taking that? Right? Kids don't necessarily like medicines, not all kids. Showing them how to measure it. Is it in a syringe? Is it in a spoon? Is it in a cup? And then kids who don't want it, how can you make them take it? What are some tricks that you can do? You know, a lot of children don't like that liquid acetaminophen. Well, they've got little baby Tylenols things, acetaminophen, right? So, or maybe they like to squirt their own medicine in their mouth, make it fun. Or maybe they like the little cup. Whatever it is, try to make it, again, play, get these kids to do what they need. And one of the things with especially children who have fevers and they're sick and going home, to write down when they give medicines when. Can you imagine having a kid sick for 4 days? Mom and dad and grandma and grandpa are all concerned, and oh, they got a fever again. Let me give medicine. Well, mom just went to the store, forgot her phone. Can I give the medicine? I tell them, write it. Right next to the medicine, what did you give and when? And now there'll be no confusion. And also, I'm exhausted by the third, fourth day. I'm not going to remember. So now I know it's the reminder and to keep kids safe. If at all possible, we like to give an oral route. And then, of course, your parenteral or all the other stuff. Now, parenteral is in many ways just an IV, that heparin lock. We have a Broviac up there. We have all sorts of central lines, PIC lines. We have ports, all different things. And you can give, you know, start the IVs and put up IV piggybacks. You can flush IVs and giving medications, knowing how much you can give. Now, an infant, an IM should be no more than half an ml. You know, infants are getting it into their vastus lateralis, right? And more than that can be too much. Toddlers are bigger, they can take more. And then adolescents, 1 ml in the arm and the deltoid, or 2 in the either leg. IV medications, as I said, goes directly in there and you get immediate effects. Now, there's a sign of an infiltrate, that little purple area there. I've seen tops of hands, tops of feet turn black and need plastic surgery. Why did that happen? Well, we should be doing really good close checks of it, inspecting it every hour for swelling. There's some medicines that are caustic, so making sure that that is a patent IV. So always checking for redness, swelling, and leaking. INOs, important. You know, the smaller the kid, the more important. We will even measure on the little infants in the newborn ICU how many normal saline flushes. 2 mLs 5 times a day is, 10 mLs. 10 mLs on a 2 kilo child could be a lot, right? So INO is important. So getting those IVs, okay, how to give it. Children today want to know what's going on. You can see we have a doll here and we're looking at things. This child has a central line in, showing her how to do it. Putting her involved makes it less frightening, and making sure she knows how to do it properly. And again, this is all depending on the age of the children. If we have to put an IV in, I know we had Child Life, and Child Life used to come in, show them the equipment, that the IV catheters are just very flexible. And then we'd have the kid, we tell, where do you want it? Which hand, right? Remember, if a kid sucks the thumb or the finger on the right hand, you don't want to put an IV in that hand. You do the other one because this is their comfort, okay? And then, of course, making sure that it's properly placed and it's enough tape, but not over taped. So calculating doses, it says here, is just how many kilograms time dose. And we can do good doses that way. When we put an IV in, again, as I said, it's where it's going to be there, making sure the kid understands. On infants, I have parents giving them a pacifier, holding their hands and just talking to them. And if they're putting it in a foot or one hand down there, we can do it. The family there, the kids feels less threatened. So that's important. If an IV is somewhere where the kid wants to rip it out, you see the use of the elbow restraints. They can't bend, they can't get to it. And that does help protect IVs. It's better than starting another IV. There are drug interactions. We do have, usually these electronic equipment that, like the Pyxis, which you can program in, get the child, and get medications out. What's really good about those machines is they're going to tell you, like, for instance, one of the antibiotics, ceftriaxone, rocephin, cannot be mixed with an IV. You're going to see, is the child on ringers? And you have to say no to get that medication. Think about giving iron to children, liquid iron. You should not put it with egg yolks. You should not have them drink milk with it. We know that iron is absorbed in the stomach. It's the acid that breaks it down. So orange juice works there. So just know that there are drugs together that can't work, even IV drugs that shouldn't even be together. Gavage feeding. Now, you have some really tiny kids or kids that have a problem with difficulty in sucking, swallowing, breathing. Or what about a child who has the whole palate, the whole upper mouth is open, and they keep aspirating foods? Well, they still need nutrition, right? So we can put in and do intermittent feedings, or we can do continuous feedings. It is a really good choice. Gastrostomy tubes, we can put the food right in the tummy. Now, usually when we have a child that gets a gastrostomy tube, they do something called a fundoplication. All that means is the upper part of the stomach is sort of kinked so they can't vomit, because you're given, let's say it's 45 mLs, it can go in pretty quick sometimes. And sometimes they'll just vomit and then they'll aspirate it. So it's something that they use as a protective thing. There are different types of gastrostomy tubes. The one up top, the thing can come off, so just a little button is left. The one on the bottom, you're going to have the thing always dangling, so that needs to be secured on these children. It's in the stomach, so sometimes it goes down through the pyloric sphincter into the small intestines. It can happen, especially on this one that's the long one, okay? If we're starting to see different colors when we're doing aspirates, looking for anything left in the tummy, if you see brown or green drainage, it's probably slipped. What would you do? You're going to tell the doctor, tell the nurse. Enemas, we have pediatric fleet enemas. They don't like to give a lot of them. They prefer nutrition or maybe a mild thing like Miralax is one they like to use. But hold their buttocks together, and then usually within minutes, these children will evacuate their stool. Always document it. One of the things is tap water enemas. It's hypotonic, right? What does that mean? If you put in a hypotonic solution, it's going to pull out electrolytes from the bowel. So you're going to go in through an electrolyte imbalance. So we don't. It's usually Fleet's enemas we give on these kids. Respirations. Well, we know they're irregularly irregular. That's just what kids are. How do we know there's problems with respirations? Well, sometimes it's too fast, sometimes it's noisy, sometimes it's non-existent, or now you have retractions. Now, if a kid is getting to the point of respiratory problems, they're becoming hypoxic, so they're getting restless. Their heart says, let me beat more to try to get oxygen around. So heart rate's going to be up. They're going to get that dyspneic. You're going to see sternal, interclavicular retractions, nasal flaring on infants. And the other thing infants do is a grunt at the end of a breath. So they'll breathe and go, at the end of a breath. We call that grunting, and you'll see those nasal flaring going on. If they have a tracheostomy, which can happen, there are some conditions that need it, always look at, the stoma. Is it red? Is it swollen? What's going on there? So suctioning, when do you need it? Well, we don't like to over suction. So, but if we're hearing, noisy, bubbly, coughing type of things, that mouth is full of secretions, or that tracheostomy or endotracheal tube is full. We need to suction that stuff out. One of the conditions that sometimes children are born with is something called tracheoesophageal fistulas. This is a connection between the esophagus and the trachea. So think about it. You swallow liquid down into your esophagus. There's a connection into the lungs, that little tube called a fistula, and it goes right into the lungs and they aspirate. And this is a condition where we would not orally feed a child. Okay? Doesn't mean that the kids any cognitive problems. It's just they need to do surgery and remove that connection there so they can eat properly. We know respirations, you have atelectasis and rhonchi and rales and all of those things. Is something to look at. Now, CPR, right? We all had to take CPR in order to go to clinicals. So knowing how to manage an airway, especially if the kid takes something in the mouth and chokes, I think that's the most common, right? So we know the younger kids is going to be those two middle fingers and try to push it out. Older kids, we're going to do almost like what they call the Heimlich, old Heimlich remover, trying to force it out. I had my son actually choked on one of those little sausages, and I had to quick get it out of him. I mean, I got it quick, but again, Parents should be taught these things, and us as nurses need to be aware. Going to the OR can be scary, and kids have tonsils, adenoids, ear tubes. I mean, these are all common day occurrences, right? With children. So they need to be prepared. The one thing they do today that they didn't do in my early career is they let parents into the pre-waiting room. They let them walk into the OR until they're asleep. And then many times in the recovery, they'll call them back. They really are involving the parents. And that does really decrease the amount of stress on that child. An older kid needs to know what it's going to look like. Many times they have teachings where they'll bring them into the OR and let them look around and see the equipment so they're not afraid of it. Before surgery, many kids can't eat, right? It's NPO after midnight for adults. We don't do that for children. That's way too long. Especially infants, they should never be more than 4 to 6 hours without something to eat or drink. So they usually will feed them up clear liquids up to that point. And then remember, how do they self-soothe? Put a pacifier in, right? So using that pacifier that can help. And then post-operatively, again, the nurse being patient, waking them up well. And again, parents does help. So an infant still wears a diaper, was admitted to the pediatric unit with diarrhea that's lasted for several days. The physician has ordered application of hydrocortisone cream to the infant's reddened buttocks. Should the nurse be concerned about this order and why? We have red open wounds on the buttocks, and we're putting a steroid on it. What do you think is going to happen?
It's gonna keep opening
For the
up.
birds.
Yeah, it's gonna get worse.
Also, they're absorbing steroids. It's like
Mhm.
taking an oral dose of steroids. And if
Yeah.
they're on a couple days, don't we know steroids, you have to taper the dose off? Will you? Usually not. So this is something that maybe a different choice can be made. That would be one I'd question. Open wounds that are reddened, blood vessels, capillaries are there. It's going to suck all that steroid in and create probably a problem for that child. Any questions so far? We do have a cahoots.
Professor, can I speak to you after class?
Oh, absolutely. Absolutely. So, there's 20 some odd questions. It's not that long, but some really good questions in this Kahoot.
Do we join this?
Yes, please.
How do you do it?
Okay, what you do is take your phone, turn on the camera, and
Okay.
that little thing up top, that QV code, put it
Yeah.
on, and you're going to see a website. Click the website, you'll go directly to the Kahoot game and put in your initial, your name, whatever you want.
Oh my God, that picture is crazy.
You will you will push the color on your phone, but look at the computer to see what the answers are. Okay, you get the colors on your phone, but you will get the things on the computer. You'll be able to see what you're doing. You know, you can take and do these cahoots with each other. Put two people, you need two minimum, and do them, you know, testing yourselves at another time. Because I always put these up for you. All right, let's just get going. So chapter 22, bunch of variations, a lot of different things to think about. After instilling nose drops, the nurse will keep the infant in the head down position for at least what? Something. So it's about 30 seconds to a minute, because if you sit them up, guess what? It's just going to run out and they're not going to get their medicines, right? When planning care for a toddler, what behaviors do we need to consider to promote security? Remember, toddlers, what are they like? What gives them comfort? And it's all about those rituals. Remember, toddlers like the same foods, the same bath times, nap times. They like consistency. They don't get it, they're going to be very unhappy. I mean, we can't do completely the same, but at least trying to be close makes a toddler a lot happier. They don't get it when you change things up. According to Maslow, what level of hierarchy of needs correlate with measuring vital signs and oxygen saturations? Isn't that your basic type of things that everybody has, right? And then it goes up to the top where things you do well, and that's all about esteem. So that's the pyramid of what he says. It's the basic physiologic needs. Yes, it is, because everybody has one. A child explains that the nurse said he got sick because he went swimming in the rain. According to Piaget, what's that all about? It's just like trees having leaves so they don't get wet when it rains, right? It's that taking and trying to explain things in a way that they get it. And it's called concrete operational, okay? It's the way that they, are thinking. Gentamicin ear drops are prescribed for a 4-year-old child. How would the nurse position the auricle? Is it up and down and back and forward? Which one is it? Again, going back to pharmacology, right? Remember, I used to teach pharmacology on ground, so I know what they had. So it's up and back, and they do it that way so they can open the hole to get it into the ear canal. Very good. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant? So up to age 5, it's apical, okay? Up to age 5, it is apical. You listen to their heart through their chest. After that, they say radial. Most accurate. A 4-year-old child asks tearfully if the IM injection will hurt. What's the nurse's most effective response? Probably that child's been hurt before, right? So now they're scared. Never lie to a kid. Never lie to a kid. It will sting a little bit. Maybe put some ice on the leg, the arm first, maybe a numbing spray, jelly, whatever. Sometimes we need to do that in order to give them their injection. Because remember, pediatrics is traumatic care. We try to give as least pain as possible so that the kid doesn't grow up to be an adult who's afraid of injections, and the adult is not going to be taking flu shots, COVID shots, and usually they sort of delay their own child's injections, and this has been proven through research does happen. And again, that's part of my dissertation for my PhD. What antibiotic is known to cause discoloration of teeth in a young child? It was one of the first antibiotics back in the 50s and 60s. It was the miracle antibiotic. And it is tetracycline. It turned their teeth that looked gray. It did something to the enamel and it turned them gray, and there's nothing you could do to whiten them. A parent tells the nurse, I'm not sure how to give this medicine to my infant. How would the nurse teach the parent? When you're giving medicine, you want to make sure they get the whole dose. So you take the syringe and very slowly on the side of the mouth, never injecting it way to the back. And in the nipple, are they going to get it all? I don't know. I mean, it's a second choice, but it's the syringe slowly in the side. It's the best choice. When should a child begin to be able to feed themselves using a spoon or fork? And I always say it might be upside down and backwards, but they're feeding themselves, right? That's how it starts. That is 2.5 to 3 years old that they should be able to do it. Yes, they're going to be trying before and all that experiments, but by 2.5 and 3, they should be really proficient. Should parents be concerned about how much fat they include in their young child's diet? Infants, young toddlers. Remember, when we start regular milk at age 1, we give whole milk, right? We don't give low fat milk because fat helps the central nervous system and it's for growth. Toddlers, remember, selfish people don't share. Toddlers are parallel play. Excellent. Good job.
Mine wouldn't even let me answer it.
Mine too.
I know it's the internet coming in and out, and I apologize. I'm going to be calling up Comcast as soon as I'm done with the class and scream again. So parallel, toddler, because they play next to each other and they don't share. As we get older, preschooler, they start playing together and sharing, right? And then usually by the time the end of preschool or school age, it's that cooperative. That's where they play checkers, playing games. Somebody wins, or there's an end of the game. They built the house, or they built the whatever. So those are your different plays, and you will see that. Which restraint is most appropriate for the insertion of an IV line in the scalp of an infant? Parents do not like scalp IVs at all. They're like, oh my God, and they see this thing sticking out, and it's usually in the center of their forehead or on either side by their ears. I've started hundreds of them. But what kids do is put their hands up and they grab it. So we can take an infant, right? And we can make them comfortable with a blanket. It's called a mummy, but it's really just giving them the comfort, but it's holding their hands away from them. Some of the older children would get elbow restraints where they can't grab it, but infants like that comfort. How often should a child who has a continuous IV infusion be assessed? Remember those pictures of those IV infiltrate, that purple ankle? And I told you, tops of hands, tops of feet. I've even seen scalps.
Just read about this.
Every single hour. Just think about if your IV solution's running at 12 mLs an hour, you don't look at it for 4 hours. That's 50 mLs. That is a lot of fluid to put in a tissue if it's not in the vein. So every hour it should be watched. What type of method is the most accurate way of determining the correct dosage for children? The most accurate. I know we use milligrams per kilogram, micrograms per kilogram, but what is the most accurate? And that's body surface area. Okay, that is the most accurate. Is it used? Only in some complicated chemotherapy things, but usually on the whole, pediatrics uses that milligram, microgram per kilogram, units per kilogram. According to Kohlberg's conventional morality, school-age children believe what? Remember, those preschoolers are all about right and wrong and a consequence for either. School-age children move beyond that. And they don't want to break rules. They follow the rules because it's the right thing to do and because they want to please. They like to please. So they're not going to break rules. What developmental level of Freud are school-age children developing to form friendships? It's one of those words I can't even tell you what to relate it with. It's just knowing school-age children are all about same-sex peers. And that's what the word means. And it's called latency. Orality is that newborn or the infant, everything, exploring the world in the mouth. They self-soothe with pacifiers in their mouth. Anally, toddlers, because they do bowel training before bladder training. And then phallic, now we've gotten into those children who are starting to explore themselves. So Freud is all psychosexual talking about that. Now, adolescents are all about body image. Erickson describes this as what? Again, I told you, you need to know what the different groups of Erickson are. What are the words? And then what does it mean? And body is their identity. That's how I remember that. And that role diffusion is like, I don't know where I fit into society. Industry is the factory, the house, the product they do well. It's the things they do good. And then inferiority is what they can't. That's school age. Initiative versus guilt is that preschooler who wants to do things, and then feel guilty they can't do things the way it should. Autonomy versus shame and doubt. Autonomy, being autonomous, all about me, mine, toddlers, and that exploration. And the shame and doubt is when parents are saying, be careful, watch out, don't do that, let me do it for you. And that creates shame and doubt, okay? Just 7 or 8 questions on your theorists. What is the final stage of Piaget's developmental theory where the adolescent increases moral reasoning? As I say, they can figure their way out of a paper bag and get what they want. And it's called formal operations. They now can figure everything out to get their way. Now, concrete operational is something that's solid, you can feel it, it's there, as in they've seen it before and they can use it now because they've already experienced it. Formal, they figure it out themselves. And then your pre-operationals, your younger children, about taking a rattle and moving it. Now I heard a noise. Oh, I like that. Or the thumb sticks in the mouth. Oh, I like that. Or throwing a sippy cup on the floor by accident and then realized mom's going to come. So let me do it again. So those are the different things of Piaget. A mother is concerned her child has developed a fever after an immunization. What education should the nurse provide? Do kids get fever after immunizations? And especially infants at 2, 4, 6 months. What are they getting? 4 different immunizations all at the same time? Well, what they say with children getting immunizations, especially the young ones, especially when they do the vastus lateralis, take their knees and bend them up and down like a bicycle and take it and it moves that immunization around so it doesn't sit. The body is trying to develop immunity and make your antigens. So it's normal, absolutely normal to get a fever. And usually they'll say, just go home and give them acetaminophen for the first day, every 6 hours. And that will help with the fever and the pain of those immunizations. So the bicycling helps, cool packs help, and acetaminophen does help, and before it becomes a true fever. Which approach is best when administering an oral medication to a young child? So it's what we call a direct approach. So do you want it with juice or water? Do you want it in a spoon, a cup, a syringe? Would you like the pill to chew? Those things help when you put them involved with it, but they're going to take their medicine. The nurse observes a 2-month-old infant actively feeding with a propped formula bottle. What facts should the nurse consider? Every parent has a time where they're going to prop a bottle on a child because they have to for whatever reason. But it does significantly increase the chances of choking and shouldn't. You should hold the bottle. If you can't feed them, well, you don't feed them right now. Let them wait because the choking and aspiration, etc., is dangerous. 6 hours into a 24-hour urine specimen, the child is incontinent. What instructions should be provided to the parent? There are things that they look at that they want a 24-hour specimen. And a lot of times they're looking for how much in 24 hours of what is excreted. So if they are incontinent, they have to restart it again. Dump out what they have and restart it. Which procedure could be performed to obtain a spinal fluid for examination? So a lumbar puncture, after when they're doing a lumbar puncture, older kids, we need to explain what's going to happen because they'll be laying on their side. And afterwards, having them lay flat and slowly elevate them and make sure they have fluids so they can get a really bad headache is really needed. What is the most effective position for the nurse to place a toddler to administer a medication? Most effective. And you're talking a toddler, a 1 to 3-year-old child. How are they going to get their medicine and get it correctly? So they should be sitting up in the crib. I mean, the other thing I would also say on the nurse's lap, a parent's lap, you have control of them, but the point of this is sitting up so that they can take it. If they're in a high chair, they're too high. They could dribble it out and spit it. But when they're semi-fowlers or semi-sitting, they're a little bit back and they'll be able to get it without choking or dribbling out. What is the most significant reason for attaining an accurate weight on a child in the hospital? Why do we do a weight when they come in? I mean, there's all different things if you want to think about it. But coming into the hospital, we want to know how to give a dose of medication. Yes, it's going to plot the growth. Yes, it's going to do growth disorders in the future. But for right now, in the hospital, is to give dosage of medications accurately. Last question, a multi. Which of the following statements are appropriate when administering medications to children? So we're never going to leave anything at the bedside medicines, anything. So absolutely not. No, we are not going to let parents give any of the medications, right? But chewable ones are easier. We know it's going to take more time to get medicines in there. And toddlers are the ones that are going to fight it the most. And then, of course, on their developmental level. Age appropriate choices is what we need. So very good, not bad at all. Let's see how we did today. Number 3, an HH. HH, good job. An AA and an A. So A was the top of the board with a B and a D. Anybody for a C? So end of week 3, if anybody does want to do some dosage calc, I am more than glad to do that. You do have a lot of the dosage calc videos that I have sent for you if you need them. If you need, please watch them. I make it very simple. And I do have the handouts that you have all in your Canvas so that you can follow along with it. Any questions? Remember, next week, I'm not here. I'm going to be giving you a Zoom to go to, and Professor Stiles will be administering exam and giving the class to you. And you will get your grades on Saturday, same time. Actually, she's doing it for me so that I can actually take a little vacation. So I'm really grateful to her. Questions, anybody?
I have a question.
Sure.
So when giving medications to children, right? I'm not quite sure which one they use in the body mass index or the body surface area to calculate what they